Yeah.
Hello, everyone.
Yes, Charles.
Welcome to this event celebrating a year's worth of the Barts Health Data Platform and rather longer years of actually building it, developing it, and making it happen. You will be familiar with some of the faces, and I'm sure they'll introduce themselves when they speak either through presentation or in answer to a question and so on. But I'll introduce myself. I'm Charles Guttridge. I'm the Chief Clinical Information Officer. I'm a hematologist, and I know a lot about East London Health and East London Services because I've worked here since the early 1970s. And I've seen computing systems develop from something called the John Ellicott Center, which was a mainframe computer system that provided computing services for most of the hospitals in East London. Some of which no longer exist, but if you walked up and down the Mile End Road, there was a hospital about every 400 yards. So there was one in Bethnal Green, there was one in Mile End, there was one in Stratford, and so on. And most of those have disappeared and been redeveloped as new hospitals, and obviously we're sitting in a new hospital at the Royal London Hospital. Barts is completely renovated and so on. But maybe to your surprise, there was computing with a patient index, the ability to make outpatient appointments, inpatient attendances, order blood tests, order x-rays, see the results, crucially, and see the reports of x-rays, although not the images, when I first qualified in 1975-76. And what I've seen over a lifetime is an amazing development of the ability to compute health and look after patients using electronic systems in a way that I think when I was just a lad, I would not have predicted that it's quite as dramatically different as it is now. And one of those big differences has been the development of the Barts Health Data Platform, which, for those of you who are still thinking about it, is in essence a replica of everything that me and my colleagues and nursing colleagues and AHPs enter at the front end of Millennium, or indeed other systems, and get transferred from the database that Oracle manages on our behalf into the data warehouse that Serge Janjuha and his colleagues started building in the 1990s, and now has a thing of extreme computational beauty, and has data that flows in from many different systems and flows out to help us manage the health of East Londoners, to get sufficient resources from the NHS to pay our salaries and all of the other things that computers can do brilliantly and used to be done in huge index books in the past. So that's magnificent. And then Stephen Newhouse, who's the one with the earphones, if you've got your thing on, he's worked with a fantastic team of people to build another replica of Serge's data warehouse, which we've called the Barts Health Data Platform, and which gives everyone the possibility of seeing curated data, which they could use either for clinical audit purposes, research purposes, or if we can get the governance right, that we can share or let others from outside use those data, again, for new discovery, potentially for the development of income by sharing data, for example, with companies that want to test out a solution or want to use healthcare data anonymized appropriately with the right information governance controls to test an algorithm. Might be an AI algorithm. It might be a way of making a diagnosis from analytical data on blood counts or liver function tests and so on. So the range of possibilities is enormous. I hope everyone on this call is familiar now that you can't just sort of walk in to Stephen's office and say, hey, give me a computer and let me see the data. It starts with familiarizing yourselves with the Barts Health Data Platform. And you can do that through the website and so on. Or by contacting Rosina, and she'll steer you to the right places. If you think then there are the right data for you to use for your research program or for your audit program, then you'd have to make an application to the Data Access Committee. And that meets on a monthly basis. It has done for about 2 years now, and maybe even slightly longer than that. And we have had not a torrent, but a healthy flow of really good applications for data from the Barts Health Data Platform in a very wide range of medical and nursing questions and so on. I think one of the areas that I'd like you all to think about is how we support professionals from allied health professions and other parts of the system to, one, record data in Millennium that then flows into the Barts Health Data Platform, or indeed flows into the Barts Health Data Platform through other systems. And there I'm thinking of, maybe there are children having audiology tests and where the sort of testing routines that children have to go to find out whether they're deaf or not, some of those data might be of high value for research purposes and so on. So there are all sorts of possibilities to develop the Barts Health Data Platform. And one of the genius things that Stephen has put in is what he calls the airlock mechanism, which allows outsiders to bring data into the Barts Health Data Platform, connect it to data assets that we have on individual patients, either through their NHS number or some other way of linking data sets, and then supporting the broad analysis of those patients across a whole multitude of things. So that's an aspiration and a reality right now. The point of the airlock is to stop evildoers introducing viruses and hacks and so on into a system that holds the data of literally millions of patients. And I'm sure Stephen will tell you how many millions it currently is, but it is millions, not just a few tens or 20s. The areas I think that we're looking to expand. First of all, we'd like to see more people apply to use the data. And one of the ways of making that possible, I hope you're about to hear from Concetta Piazzi, who's building tools that show people more easily what's actually in the data system. And she's supported in doing that by Ben Eaton, who does a lot of the sort of actual construction of the data system. And the ability to see what's there then encourages people, I think, to think about, so what questions do I have to answer about the patients that I look after? It would be healthy and sensible to think of those questions before you start. But I recognize that sometimes it just helps you to know what there is. And there is an amazing range of stuff: free text, structured data, problem lists, terminology lists, imaging of all kinds, lab tests, histopathology results, and so on. And I would hope that as soon as we make digital pathology, the viewing and reporting of the sections of human tissue that are produced every day from patients' tissues, those will also, in the end, link up to this system so that we can begin to answer really complex questions about how somebody's DNA links to the pictures in their X-ray, to the sections that are taken from tissue taken from the thing that was X-rayed, to the lab results that are all there, and also, crucially, the outcome of an individual patient. In other words, did they get better from the condition? Did they get worse? Did they die? All of those questions about life expectancy and life quality that can be answered from electronic health records will come to be available through this amazing system that Stephen has built. What other plans might we have to broaden this? So Stephen and I and many others have endlessly thought about how could we flow data from primary care into this system, or at least link data in that from primary care with that in the secondary care system. And we had an application only a couple of weeks ago of a group of hospital doctors and GPs who want to improve the identification of patients with chronic liver disease who are at risk of developing hepatocellular carcinoma. If you're in that situation and the disease has already spread, then you'll basically have incurable liver cancer. On the other hand, if we know you're a high-risk individual for liver cancer because you have chronic cirrhosis or you've got hepatitis C or HIV and so on, then it's possible to screen individuals and detect liver tissue change early and resect it or treat it with radiotherapy and so on, and prevent the development of much more serious disease. So there's an opportunity of using primary care data, hospital data, and the long sequence of care that comes with patients with chronic liver disease. That is a real event in our data platform and might be a game changer in the long-term health of those people. Oh, she's telling me to shut up. So I've done my bit. So primary care data, and the other is we'd like to share our data in the long term with the secure data environment for London. And that's part of our plan as well. And so we have a jewel. And I'd like to thank Stephen, first of all, for doing an absolutely brilliant job. And then everybody that works with Stephen and on the whole team for creating a thing which will have a long life and help patients in an extraordinary way. So thank you very much.
All right, thank you, Charles, for that introduction and for setting the scene so wonderfully as to why we are here and what the focus is that we have. So I'm going to start off by filling in some of the details around what Charles has talked about, and looking as to how, as Charles summarised, really the data platform is trying to find ways to simplify secure access to our patient data to generate clinical breakthroughs in East London for a healthier future for all. And this is part of a wider precision medicine programme that Bart's Charity has invested in over the last 3 years, with a couple more years to run. And this is helping us and comparable research groups at Queen Mary look and to demonstrate what the power that patient data and the information that holds within it has to benefit our local community and patients. So this work started initially just right before the start of the pandemic in 2020 and was put on hold while other more important matters were dealt with, but restarted a couple of years later by bringing in a team to start establishing what the basic infrastructure of the data platform would be, and then taking that through the further support from Bart's Charity into the start of the implementation. This implementation is now 18 months or so old, and it's a year since we did our minimum viable product launch and 6 months since we did over 6 months since we did our public launch. And so we feel we're now in a relatively stable place in terms of the platform's functionality, and we're continuing our work to expand the types of data that we hold to round out that offering for our potential user community. And this includes not only the sort of the textual records that exist within the electronic patient records in the trust, but also images and other data that is basically being recorded. So anything that goes into the system within the hospital, we want to be able to pull out and present to researchers and clinicians within the data platform for them to analyse. So what do we do? So essentially it's two things that we've provided and established over the years that have been needed to fill in the gaps that existed previously within the hospital. Firstly is the process around actually attracting applications, deciding on a data release, and then actually making it happen. Previously, this was very spread out in terms of the teams that were involved in this process across the hospital. And what we've been able to do is establish a very clear front door, which all data access requests can come in through, and also, any broader use of patient data. Sitting behind that front door is a team to process the requests, and most importantly, the Barts Health Data Access Committee, which brings all of the interested and essential professionals across the trust together to review and to make sure that the requests that are being asked for are compliant with all of the legislation and have got good information and research governance associated with them. And you can find out more information on the website that's there. Once we've agreed to release data, we need somewhere to both put the data and to have collected the data. And this is the technical part of what we've been doing over the last 3 years. So as Charles says, we have essentially a data warehouse or a data lake in modern parlance that brings together all of the data sources that we can get access to across the hospital, and to bring those into one place and to make sure they're linked and consistent across all the different data sources that we have. And what we're able to do there is to facilitate access in a secure data environment to users who want to use that data for either clinical research or increasingly collaborative commercial work as well. And as part of that environment, we're also able to provide the infrastructure, which is incredibly different from what is provided routinely across the hospital. Very large machines with large amounts of memory, large amounts of processors, the exotic GPUs that many people are now using and are the backbone of the artificial intelligence and machine learning services that are common across many organizations. And it's through having this range of data and the secure environment with this range of computing infrastructure and data infrastructure to analyze that data that we feel that we're in a really good position to support both population research and research in specific diseases using a vast range of the data that's held within the hospital. Unfortunately, none of this is core NHS business, so we are very thankful to the funding from Barts Charity that have provided a dedicated team to support this work over the last couple of years. So the Data Access Committee, as Charles indicated, has been running for over 2 years, 2.5 years, and we have about 2 to 3 projects a month. And there's more information online, but the key thing to really look at is to see the split that we have essentially between research and non-research or clinical activities coming through in the project mix. Not surprisingly, most of those are from the Barts Health, But obviously we work closely through the Barts Life Science collaboration with Queen Mary, and so we're seeing just over a quarter of our users being driven by that research angle, also taking place collaboratively with members inside Barts Health, and increasingly a range of commercial and other organisations looking to seek access to the data to support their research activities. And it's important to say that the data platform is open to anyone who can show legitimate purpose to access the data. So what sorts of data do we hold? And Ben, who following on will talk more about this, but we have access to the structured clinical data that exists. Whoops, that wasn't supposed to happen. And let me go back a slide. We have access to the structured clinical data. The free text that is part of that clinical data is available inside the data platform for use. We're also able to expose the data that we hold into particular formats, and one of these is an international standard that makes it possible to compare data from different hospitals very easy. And this is critically important if you're trying to spot patterns where you've only got a small amount of relevant data at each particular hospital. And so in addition to that, we now have access to the data, or the imaging data that's held in the hospital systems, and a range of other data. And again, all of that is accessible through the Barts Health Data Access Committee with the appropriate positions. So looking at the numbers a bit more as to the sort of data that we hold, we have got over 3 million patient records, which expands by over 1 million patient encounters each year. So that's not 1 million new patients, but both new and old patients coming and interacting with the trust in various shapes and forms. And you can see there the sort of the age distribution and the split between male and female patients. We're also able to pull out of that the sort of different diagnoses from the patients that we have. And this obviously is interest to particular researchers to come along and see what sort of type of data we hold on particular patients. And you'll hear later on about the cohorting tool being developed within Barts Life Science that enables to do much finer grained extraction of diagnoses and to look at the population who have that diagnosis than you can see on that slide at the moment. We're also able to couple it with other bits of information. And one of these is coupling the patient information with both the information we hold on ethnicity, but also the information taken on sort of the generally accepted sort of deprivation index that exists and is drawn from the patient's address. And this helps show that the ethnic diversity of the East End of London, but also some of the challenges we have in terms of healthcare in a very deprived, ethnically diverse location. So all of the data that we have, once you've been approved, is accessible through the secure data environment. Like many systems nowadays, to get hold of sensitive information, such as your banking details, you need to go for a multi-factor authentication, and you then gain access to a dedicated account, which shows you the workspaces where the different projects you may have access to, you're able to access the data within those. So this provides a way for the individual patient data to stay local within each particular project that you may have access to. Most people probably only have access to one, and enables that data then to be processed in that workspace and with very considerable restrictions on what data can be exported out through the airlock process that Charles mentioned earlier. So coming up from the rest of the meeting today, we've got Ben talking about the various technical aspects of the platform, focusing on the data. We then have a case study from CETA talking about the Predict project, the hospital's information governance lead Data Protection Officer, Sarah Palmer-Edwards, will talk about how the information governance role in terms of supporting use of the data. We'll then have some slides and demo of the patient cohorting tool, and then wrapping up with communication engagement from Francine before I'll come back to sum up the workshop. So I think with that, I will stop showing my slides and hand over to Ben to carry on.
Hi all, I'm just getting the slides working. So for those who don't know me, I'm Ben Eaton. I manage the data aspects of the data platform. So I'm presenting on the technical aspects. This will obviously be more focused on data because that's my area, but we do also have our cloud team in the chat, so still feel free to post questions about that. So some of this is what Stephen has already briefly mentioned, but we have over 3 million patient records, and we get 2 million new data points on our patients every single day. On average, we have over 170 million distinct clinical documents, about 10 million images, 750 million measurements, and as Stephen sort of mentioned, one unique thing about BARTS is our quite diverse population. So over 40% is non-white. Right now, I believe we are the largest secondary care OMOP database in the UK. Population demographics, this again is pretty similar to, I think, some stuff Stephen showed, a little bit more up to date, and you can see the ethnic breakdown and the age and sex breakdown. So right now what we offer to researchers is generally broken down into 4 key data products. So one is what we call the research data extract. So that's the extract of the records built specifically for research purposes. So there's 17 different tables and over 650 different columns. We also have the raw Millennium tables that we use. So any data product that we build out of the raw tables, and we also host the raw tables as something that people can request. So if you're a much more technical user or more advanced user and you want to get the source data so that you can do your own mapping and your own transformations, we can support that. Then there's the OMOP data. As already mentioned, there's about 70,000 concepts that we've mapped into OMOP, and this is a standardized ontology which allows you to do queries across sites. So you could, instead of just relying on the 3 million people at BART, you could easily get to a few tens of millions by federating over the UK, or you could also federate over Europe or other sites in America for really, really large analyses. And imaging data, we have about 10 million images. And we also have the linked reports for those images, and we've anonymized the reports and the DICOM tags that come with those images. So this is the research data extract. So I mentioned these are the different kind of clinical areas. So a lot of what you would expect, so the inpatient, outpatient, emergency, the different measurements, family history, cancer, so on. The way this generally works is that the first step is to define a cohort. So some researchers, they have a list of people, say, on their study. They can give us a list of NHS numbers. We go from there. With others, we need to work with them to define a query. So patients of a particular age range on a particular drug, so on. Once the cohort's been defined, you get your approvals. Once you have your approvals, the CSV files for each of these tables will be sent into the secure environment, as well as schema information. So you will get information on what every column in every table means. This is a breakdown of our pharmacy and drug administration. So we have a e-prescribing active now at BARTS, so you can get fairly precise about the different kinds of drugs that we're prescribing to people. And we can, because we map this into OMOP and into SNOMED, so you can use SNOMED's a straight expression constraint language to get like full lists of drugs that specifically you're interested in. We can also use something like the ATC classification. So you can see here, like, this box is a whole category of the nervous system drugs, and then within that you see the different main subcategories of nervous system drugs, and then you can go even deeper. Imaging data. So as I said, we have about 10 million images, and we can break this down into different modalities, so, X-rays, ultrasounds, so on. And also location of the images. So this heat map on the left is the location of the images that we have in bars. So you can see like a heavy red area around the head. That's probably what you would expect. Similar around the heart. You can see big areas around the hips. That would probably be X-rays for hip fractures and so on. So the OMOP data, this model, that's what I mentioned before, about 750 million measurements, 35 million visits, and 68,000 concepts, sorry. This doesn't require anyone to have any specific knowledge and allows them to collaborate internationally. We use a transparent data pipeline. So what that means is we start with the base, so the Millennium data, and then we use several different steps to transform it into a gold standard data set like OMOP. Each of these steps, the full code for that is accessible on GitHub. So anyone who wants any of this data can see every step that we've taken. So this is what you would call a reproducible analytic pipeline. It also means that if you don't want a particular step, like you don't agree with one of our cleaning steps, you can request the data at an earlier stage, so say the raw Millennium stage, and then you can take our code and just change the bit that you don't like and apply it yourself and get the data in the standard that you want. This is built to process really large amounts of data. So as mentioned, we get 2 million new data points a day. So to transform that through a whole pipeline into standard, obviously is a fairly big job. So we use Databricks for this, and a feature they have called Delta Live Tables with incremental updates, and we use Apache Spark. So for those who are unfamiliar, Spark is a way of taking a compute job, breaking up into small parts and distributing it so it can be run over many different computers at the same time. So you get sort of like fast performative loads. The other useful thing about tracking our pipeline in GitHub means that if you got data at a particular point in time and you need to get an update of data at that point of time, we can use GitHub's version tracking to go back to the code that was exactly used to produce your data set. So we can either give you that code if you need it for publishing purposes, or we could reproduce the data set at that point in time. This is our de-identification system. So this is something reasonably new we've been working on. So there are many technologies out there that allow you to de-identify documents using like NLP approaches, but their accuracy is not brilliant. So they usually range between sort of like 90% would be a good one, maybe 95% would be ideal. But they work particularly badly on the BARTS data because of our diverse population. Like we have a lot of people with like less usual names. And the other problem you have with them is even if you get to 95%, you don't know what the 5% are. So there could be one patient where actually it failed completely, and all their details are there, but you know, in the bundle, they'd still say that's 95%. So we developed this programmatic system of de-identification. So because the hospital will store all the addresses that we've known someone's at, all the names we've known someone's at, all the IDs that we've known someone has, as well as their date of birth and like, we can use that to redact all the information out of the free text for that specific patient. So while this isn't perfect, there are some things that could slip through, like if someone's misspelled someone's name and the like. For everything else, it works much better than the NLP approaches. And more importantly, we know exactly where it's going to fail. So we know it'll fail on misspellings. We know that it will fail if they mention someone else. We know that it won't redact doctor names and the like, so that the IG team can make a very like informed decision of if that level of de-identification is good enough for the given project. Geographic and environmental data. So this is the same chart that Stephen showed, which is IMD and ethnicity. And I particularly like this chart because you can see the interaction between ethnicity and deprivation. So you can see like in the more deprived cluster of our population, there is more diversity, like a lower white population. So every single patient we've mapped to their LSOA, which is like a sort of geographic area, and the UPRN, which is a unique identifier for the given address. That allows us to link to, as well as deprivation, also air quality. So I think we have 15 different pollutants that we've tracked sort of across the UK. So if you have a particular patient, we can go to their address history, know this is where they were living at this particular year, and then look at like what the concentration of pollutants was in that year at that time. Bad timing for a phone call. Yeah, so in summary, what we have available, these four sort of standard data products, as well as additional data on drugs and pharmacies, geographic and environmental data. And all of this is processed through transparent and version control pipeline with full visibility. I think that's the end. So obviously there are questions, but I think there's a specific box for Q&A I'll be answering during the during other people's presentations. So I can probably hand over to the next person now.
Osita?
Hi, can you hear me?
Yes.
Can you hear me? Okay.
Hi, okay, I'll share my screen. Let's start this. Just a minute. Can you see my screen? We're good?
Yeah, all good. Thanks, Osita. We can see it.
Hi, hi everyone. I am Osita Nwebu. I'm a data scientist with Path Life Sciences and currently the principal data scientist working on the Predict project. In the next few minutes, I hope to show you guys how I've been able to use the data within the SDE in a data-driven solution to address the problem of undiagnosed valve disease in Northeast London. So Predict project is a clinical pathway development project funded by BAS Charity, and it aims to reduce the number of emergency presentations of life-threatening severe valve disease in Northeast London region. It will aid in the focusing of mobile community-based diagnosis towards the areas with at most risk of getting the disease. All right. First, severe valve disease, heart valve disease affects people, 50% of people over 65 years. At the moment, it currently affects 1.5 million people in the UK, and this number is expected to double in the next 2 decades. Stenosis, where the valve doesn't open properly, and regurgitation, where it doesn't close normally, are the 2 significant diseases that affects left-sided mitral and aortic valves. It's an asymptomatic disease that can easily be treated and treated safely at a lower cost if detected early. So the problem with this is the fact that a lot of presentations are made in an emergency situation, and this results in an extra cost of about £5,000, and it gives us here's a distribution of the cost. We can see here that we've got about 45,000 if it's treated in an emergency presentation, and then 40,000 if an elective pathway. So converting a single patient from emergency to elective pathway will save us 4 critical bed days and 10 days in total, and a savings of about £5,500. In 2022 and 2023, about 500 elective valve interventions were seen in Northeast region, and then 394 unplanned interventions occurred. And if there's a 10% swing from unplanned interventions to elective pathway, we can save the practice, just 10% will save the trust about £200,000 per annum. And so it becomes very necessary for us to address this problem, given the high cost. And so the solution to this was to conduct a study to check the geographical mapping of areas where this is likely to be found. And the study that was commissioned showed that about 11 of 117 practices show there's a kind of clusters of people with undiagnosed valve disease. So this map shows hospitals and GPs around hospitals, and it shows that certain hospitals, certain GPs had significantly higher number of acute presentation of severe valve disease. And so the study showed that an outreach of echocardiography provision in these regions could potentially identify patients with valve disease before acute decompensation. So it becomes necessary that we can go to these areas, try and find the patients that have got this disease and then target them. Unfortunately, going to the practices is not ideal because we've seen from the data that there's unreliable coding of valve disease. About 53% of diagnoses are correct. Only 53% of diagnoses are correctly coded in both secondary and primary care. and 18% are coded incorrectly, while 29% are not coded at all. So that means that we cannot go to practices to address this problem. There's limits of identification and correct follow-up of patients. These are kind of the problems that we might experience. And this leaves many at risk of not being followed up with best practices. And then indiscriminate screening is also not desirable in this situation. So we must look for another solution to this problem. Bath Trust engaged in a community-based diagnosis testing, which was the London Valve Reduced Ejection Fraction study, a community-based diagnostic approach using mobile handheld devices to scan willing volunteers aged 65 and above. Now, this scan was kind of successful in the sense that it was delivered by non-expert scanners with oversight for both artificial and human intelligence. And 35% of people, of 518 participants, were suspected to have the disease. And following a secondary scan, 88% of those individuals, 88% of the suspected cases were later confirmed after a secondary scan with proper CT scans at the hospital. So despite these excellent results, the community testing approach needs to be better targeted because of the diverse nature of the population, the makeup of Northeast East London. So there's a risk that underserved communities will miss out of this initiative. So that's why the fact that we can use this mobile device, scan patients, invite them in for studies, certain individuals in the community will still miss out. So some of the key issues that were found in Northeast London is the fact that it's made up of a diverse social community, including Tower Hamlets. And then there's still health inequalities that persist within the region, with lots of people experiencing barriers to accessing healthcare due to the very huge migrant population and ethnic minorities. So information about social conditions that can help us identify such patients are not easily coded with SNOMED codes or exist in structured formats. Such data sits in the data warehouse as free text notes. So the SDE gives us an opportunity that we can mine this data, use NLP techniques to mine this data. So Predict Project comes up with a solution to this problem by adopting a data-driven approach where we're going to use NLP techniques to convert the data, convert unstructured data into structured SNOMED concepts. And then we use the entire data, structured data from both primary care and from secondary care, combine this with open source geospatial data, and then build a geographical map of locations where people at most risk of the disease are likely to be found. Now, this project is in collaboration with UCL geospatial team. They've got the expertise in anything to do with geospatial analysis. So they're going to build the geographical map of people in Northeast London where we're likely to find the disease. And then with this map, the community-based testing efforts will now be better targeted because we can easily identify the locations where these people are likely to be found, and then we can take the device to them. So the project is split into two. The first part, work package 1, is where we, first of all, identify patients from the e-postcode area with patients over 18 years whose first echocardiogram was done within 7 days of an emergency visit, followed by a valve procedure within 365 days, within a year of that visit. And so in the SDE, we've been able to identify about 2,961 of such patients. The first goal approach of this project was to then extract the echo reports from the database. Echo reports are stored as text documents in blob formats in the database. We extract this and then use various NLP tools to extract the outcome, to read through the text and extract the outcomes from the reports. And then this is compared to a ground truth by the clinicians. So how do we come up with the ground truth? I'm working with the cardiologist, expert cardiologist at the BATS Cardiology Health Center. Dr. Joshi. So we've given him access to the SDE. He's got his own VM machine, and he has access to Label Studio 2, where he can import the documents into this tool and then manually, as you can see from this screen on my screen here, can manually annotate the documents. So that means reading through the documents, selecting those entities of interest, and mapping them correctly to whatever entities that we're interested in mining. And so the output of this is then used by myself in an NLP tool to then apply to the rest of the documents, compare the results of what I'm doing with the rest of the documents to see if the tool is doing an excellent job or not. So first, what do we mean by named entity recognition? What is it, and what's the linking all about? Named entity recognition is an NLP task. It's a natural language processing task where a model automatically finds and labels important pieces of information in text. So it scans a sentence, like in this example, I've got this is an example from Spacey, where a simple clinical test is given, and the tool would automatically find the entities. And so in this case of predict, we have to manually specify the entities of interest that we're looking for. And then with the guidance from the clinicians and the manual annotation that's been done, we can then direct the tool to identify those entities in other documents. So why is NER, named entity recognition, useful? It's a good means of extracting structured data from unstructured data. As you all know, structured data in its current form is readily available to researchers. So you can easily conduct research, query the database, and do all sorts of things with the data. But unstructured data, such as free text, where clinicians can freely put in information, are often ignored. So it contains quite rich information, and no one looks at it because it's in text format. So NLP allows us, this approach of NER, named entity recognition, allows us to extract that information and then link it to a knowledge base like SNOMED. So in this case, we're going to link whatever we're finding to SNOMED. And then you can then run queries, build your downstream machine learning tasks like prediction and classification, and then link whatever we have to any other form of ontologies of interest. So entities of interest that we're looking at are diseases, findings, medication, but specifically we're interested in social determinants of health. These are information conditions that would that would inform the social status of the patients that we're looking for, and then can help us build a digital map of where we're likely to find them. So the tools are available to us. A couple of tools that we can use. CliniThink, which has been successfully used in the diabetic foods project, but CliniThink, unfortunately for us, CliniThink went bust. Then we're going to use Hugging Face transformer models, which includes BERT transformers and LLMs. And then we also have MedCat. MedCat is an open source tool, NLP to NEL tool that can also do the job for us. And then we also have ChatGPT, the GPTs, not necessarily ChatGPT, but GPTs that are available within Azure Machine Learning. And I know the question will be if we trust the data that is being sent through an LLM via API calls. We've also introduced, or rather, we also have as an option to also do this locally with our own Hugging Face models. So we've downloaded various transformer models, transferred it into the SDE, and we hope to use those models and avoid the situation where we have to answer the question if we're sending sensitive data across to anyone. So Meta Llama 3.18 billion parameter model is one of the examples of models we're going to use. So essentially what we're doing, since Clicks, which is CliniThink, is no longer available, we've moved on to MedCat, the machine learning and LLMs. So essentially what we do is we use the manual annotated documents to build a data set, either by building more synthetic data, because we need tons and tons of annotations. But our clinicians are quite busy. They're the experts that can do this. So they're unable to give us the volume that we want. So a solution that has been suggested is using one of the LLMs to generate our own synthetic data, so we can use that to train a model. So what we mean by this, in machine learning terms, is just simply saying that we need more examples that the algorithm can learn from before it can then automatically map what it's found into new examples and then identify the entities from unseen examples. So another way of doing this is having the clinicians, like I said, document this, annotate tons of documents. Because we don't have time, we have I think it was a MedCat solution that one of their new models, they had annotated about 17,000 documents. And so since we can't get to that number to make the model efficient, we would have to make do with synthetic data. So part of the process will involve fine-tuning the models that already exist. Fine-tuning is just a way of tweaking existing model a bit to your own data. So you feed it your sample of data, and then you tweak, maybe it's a final layer of the model that you're kind of like changing so that it can address your own problem. So we'll do that to the existing LLM models and then use that to process our documents. In the interim, we also try to show the performance of the models. We're not just plucking out any model out of the bag. We have to test to see which one can do a fantastic job. And so we've got metrics that would help us, evaluate to see how well the model is doing. So as a demo, at the onset of the project, we try to show that we've got this ability to do this and work tool that can be available to us. The GPT model from Azure showed that the LLMs seem to do a better job in identifying the entities, possibly because LLMs are a lot better at language understanding. Clicks before it went bust, without any Clicks and MedCat models that you see on this screen, were the default models without any fine-tuning, without any further training. And it didn't perform as well as we thought it should. Well, not as well as we thought it should. It was expected that Clicks was more optimized for clinical data. Whereas what we're interested in this example is social determinants of health, which is often ignored in most of the studies or most of the tools that are available. So because we're a key factor of this is being able to identify social determinants of health, it hasn't done a good enough job. And unfortunately, they went bust. So we're no longer going to use them. At the moment, the GPT-4 and MedCat and Spacey, the Spacey outcome that you see here, Spacey was kind of guided. So this requires a lot of manual intervention to get it to do as well as the others. So it's basically us writing the code, and identifying the entities of interest that we're interested in finding, and then guiding it to be able to find those categories. So the problem with this is we have to know more of the possibilities that would exist in the data. So this makes it a little bit infeasible to do that manually. So another comparison that we did was to look at the LLM versus MedCat. So now MedCat is a closed solution because it's already out there, open source tool from Cogstack. And then the LLM via the Azure machine learning, we just try to compare the two to see what outcomes that we can show from the results. So we can see that the LLM was doing better than MedCat in social determinants of health. The MedCat wasn't trained at all to identify social determinants of health. So that shows us we still have a problem with social determinants of health. So we need to actually train our own models to be able to identify them. In terms of medication diagnosis and other findings, well, it did okay, but not as good as we expected. probably because the entities are so granular. So whilst we're looking for findings and diagnoses, it could also have different categories or other terms that have been used to describe the same entities that we're looking for. So it identified them, but it's placed them in a wrong category. I wouldn't say wrong category, but in a category that we're not looking at. So that's probably the reason why. And next was to also look at tons of documents, the document types that we have, because we don't know beforehand which document would have the information of interest. There are loads and loads of different document types, different letters, different free text notes. So this is one of the challenges that we faced with mining data from the SDE. The documents, we don't know which one would have the information we're looking for. So we have to look at tons of them and then try and figure out which one is giving us the best information. So here we can see the E.D. Clarkin notes contain lots of information about SDOH, clinical findings, and or this example is for findings. So that's where we'll have rich information, rich text that we can mine. And so we've done this for about over 130,000 documents. And here's the outcome. And so the next stage of the project, so the second stage of the project means I take the data that I've extracted as structured data and aggregate them using the LSOA.
Sita?
Yes? Can you hear me?
I'm sorry to, I'm sorry to interrupt you, but we need to keep to time, I'm afraid. Would it be possible to wrap up your presentation in the next minute or so, please?
This is the last slide.
Okay, thank you.
So this is the last slide, yeah. So the next stage of the project is our collaboration with the guys at UCLA. And so this is where I extract all the data, the structured data from the SDE and aggregate them by LSOA and then pass it to the UCLA team. They would then use it to build patient clusters and a geographical map of areas where we're likely to find the patients. So it's still work in progress. Thank you for the opportunity. Thank you for the time. Finished. Done.
Thank you. Next we've got Sarah.
Hi, thank you. Hang on, I'll just bring my slides up.
No problem.
Can you see my screen? Yeah. Hi, so I'm Sarah Palmer-Edwards. I'm the Head of Information Governance and the Data Protection Officer for Barts Health. And my team received some of the funding from the charity bid to kind of input to this work, both in the kind of creation and design of the actual data platform, but also the kind of ongoing processes. What I was hoping to cover today is really just to kind of give a perspective from information governance and actually really like how beneficial this type of kind of approach to use of data is for us, but also to anybody applying for it because of the reduced information governance requirements, which I'll kind of take you through at a high level. Hang on, sorry, let me just go to my next slide. So I think these two statements, I think hopefully everybody will agree that they're both true, but actually, so information governance is important. We need to keep data safe, and it's really important that we make sure patients trust our use of data for secondary purposes. But it can slow down the data starting to flow, and it can have an impact on the timeliness of that important work starting, whilst all of those checks are made and the approvals are obtained. I don't think there's any getting away from that really, and I think it's been acknowledged in several kind of national reports about the kind of current situation around use of data. It's not down to like our individual team's way of doing things. It is ultimately just because of all the different kind of checks and balances that need to be done. And actually a secure data environment like the Barts Health data platform does really help to reduce the burden, but also does this in a way that actually not only doesn't compromise on data security or insurance, but gives a greater level of it and makes it safer. So that's my sales pitch of actually why the data platform is a really positive thing from that perspective. And we see this kind of comparison using the metaphor of the library. So, you know, what we were doing before would have been like a lending library. You've got this lady sitting in her house reading a book. And actually, this is that we would be giving data out to people. It would be, you know, sending them a spreadsheet, working out the best, most secure way to send it to them. They've then got it on their own system, so we have to consider that. They could lose it, like you lose a library book. I know I have before. Someone else might see it or read the book. We've got no kind of oversight of how they're using it. If they delete it at the end, there's that kind of need to actually try and follow up to make sure that they do fulfill those commitments to delete the data, etc. Whereas the reading library, so, you know, you keep it in the library, you read your book in the library, that approach is the data platform, and the data can stay in the environment, be used within that in a secure way that we retain full control of. So, you know, hopefully that makes it clear that the difference here and why the IG does become actually kind of more straightforward. You know, and ultimately is the reason why there's the National Programme of Secure Data Environments, to try to kind of help all of these things to be true, both in terms of security, but also in terms of ease of access and use of data. You know, and as an end result, the benefits from an IG perspective are that you've got reduced data movement because it stays in that one controlled location. It lowers the risks of accidental sharing or keeping it excessively after you finished using it. It gives improved oversight and auditability. Enhanced cybersecurity. You know, ultimately we've assessed this platform once that is secure. We don't have to constantly assess different transfer mechanisms where people that are receiving the data are going to be storing it, how they're going to be storing it. And the access is controlled and auditable. And actually it gives the ability to have greater transparency as well. And I think transparency in this is really important, and actually as much so really as for anonymous data as it is for identifiable data, because I think a lot of patients, they still would like that transparency of how their data is being used, even if it has been anonymized. And I think what you see on the Barts Health Data Platform site is that kind of transparency of the different projects and the different types of data that are being used and how. So, you know, so what does this mean for applications? I mean, really, it becomes easier to get access to data that's already anonymized. So because the process of anonymizing data is data processing, you know, sometimes we will get applications from people who ultimately want to use anonymous data, but they still have to work out who will anonymize it first, which means getting access to the identifiable data and anonymizing it. And often that can only really be done within the care team. So then you've potentially got to have people doing that. That is a time-consuming task that you know, could be done elsewhere if it wasn't for confidentiality requirements. You also got the ability to have like linked data. So Stephen talked about potential for other kind of data feeds, and Ben took us through some of the different types of data in there. But actually one of the key reasons that people need identifiable data is because they then want to link it to other data sources. But the beauty of a kind of secure data environment is that you can do that linkage within the platform and have your data set, and then you can provide it out in a kind of anonymous way. So there's that kind of increased likelihood that you'll be able to get what you need with the lowest level of assessment and approval. And it allows us to have controls around things like anonymization at that kind of central expert point. I mean, I should have just said Ben on here. You know, Ben showed you his kind of free text de-identification process. You know, I think that's been like a wonderful piece of work. It's opened up options around free text that we wouldn't otherwise have. And ultimately, we would have had no choice really but to just say that people can't have that free text data without that tool that's been developed at that central point that gives us that confidence in providing the data out. And I think it's different because we're working with that kind of one central point. We can have some confidence there are set processes in place for anonymization, rather than dealing with like lots of different individual people within the care teams who are trying to do that process themselves. And back to access, you know, if the data is being accessed in the data platform, then, you know, there is no security to assess of a transfer mechanism, where it will be stored, how it will be stored. So, and all of these things really result in an increased likelihood that IG can support an application, and that because of it meeting the principles, being things like data minimization and security being the key ones. And as a result, it streamlines the approval process. There'll be less cases where you do have to kind of seek a Section 251 application for a waiver of confidentiality because you've managed to find a way to get the data in a non-confidential kind of form. I mean, being realistic, there are still things that we have to check and have to assess. And obviously, if it is identifiable data that people want, some of those things still apply, like the security elements, all of that secure access. Still streamlines the assessment process, but we would always still need to make sure there is an actual legal basis for someone to see identifiable data, both from a data protection and a confidentiality perspective. So, there will still be checks that we need to do, but it still is significantly reduced by some of those other key things being taken care of. And also, we will always need to continually advise on whether data is actually anonymous in certain scenarios. And the example of the free text was a good one. Like, there'll be use cases where something will come up for the first time, and then we'll work with Ben and the team to decide actually, can that be anonymized effectively and make a judgment. So I think as we build up the different use cases, that's when we'll continue to see things being streamlined. So now we have that solution for free text that can apply to other cases in the future. But yeah, so I think in a nutshell, really, like it's a great approach to use sort of data in a big way. Like, it's in some ways more data processing up front to create this kind of vast data set that can be available to people, but with huge kind of benefits to applicants who then want to use it, because the processes are streamlined on the application by application basis. And really, I would just really encourage people to consider whether they can get the data that they need from the SDE because of those increased kind of security controls and streamlined processes for IG. So that's a bit of a whistle stop, actually, but I know that we've gone over on the last one, so I won't extend it more than I need to, but I am happy to take questions, and I've also put our team email address on here. So if anybody does, ever want to follow up, it's best to use a team mailbox, because then we can kind of make sure it's picked up by myself or someone else in the team. But I'm happy to take questions now if we have got any time.
Thank you, Sarah. Oh, Jason?
Hi, Sarah. Thank you.
Hi.
This is a question as well that I have that I put into the Q&A a bit. But so if let's say I want to explore how a particular area uses the system, and the example I gave is a pretty generic one in terms of how many times an area would use lying and standing blood pressure readings to determine is that a factor in terms of this area having a lot of falls. The information is useful, but what I would also be really useful for me, and I'm thinking of this as a kind of a training tool, is identifying folks who are doing things well and identifying staff who are doing things not so well. If I did get access to such data, do I also get access to who's recorded a particular thing?
I think I'm going to have to defer probably to Ben on this one. I don't actually know what we hold in way of kind of what staff, who has added the data. Sorry, Ben, to pass it to you, but is it one you can answer?
Yes, so that data is there. So every sort of Millennium event has like a personnel ID against it, which we have access to. Like, I don't think we've ever linked that to an actual person before, because we've mostly been research focused, but we definitely could do that if there was a request was approved to do that.
So who do I need to talk to get my request approved? So I've just started on the multiverse data apprenticeship, and what I thought I was going to have to do was to learn how to use SQL and just access the data warehouse natively, and that was going to be forever. Now, I've been talking to Dr. Charles Guthridge about this since 2015. But this is me, Charles, it's not you. But I just think, we've got such a huge resource. I don't think I'm going to make the trust any money out of this unless we consider making our staff better at what they do, then makes us more money down the line. But how would I go about applying for this? And it's probably better to have a conversation rather than take up a whole meeting on this. But how would I have a conversation in terms of seeing what's feasible, what I can do, and what I can't do?
Yeah, I mean, I did go to our website or talk to Rosina about making an application, but obviously, like, we can also chat, you and me, at some point if you want to. Need to talk to you through the data that's available.
That would be awesome. Thank you very much indeed.
Sure.
Jason, I have provided a link to our website in the Q&A section. So if you want to just have a look at our website, create an account and just go through the application form. And if you have any questions, you're more than welcome to reach out to us. Okay. Sarah, there's a question for you in the chat.
Yeah, I was just trying to get to it.
Okay. It's how confident are you that this data? Can you see it? How confident are you that this data is?
I'm looking in the Q&A bit, but it's somewhere else. Sorry.
It's in the chat. It's in the chat.
Oh, okay. Hang on. Sorry, 1 second. Can you? How far back is it, Rosina? Sorry, I can't find it. I'm just having a look.
Hang on 1 second.
Sorry.
Here, I've just posted it again.
Okay, so how confident are you that this data is very protected because of things like data phishing? I mean, I think Charles might have answered a bit of it as well. So Charles has said we have routines to detect cybersecurity breaches all the time. We're confident, but not overconfident, as humans do many things that are troubling for data safety. And I think that's exactly it. Like we make sure we have every technical and organizational control that we can have for these things. But ultimately, what I would say about cyber attacks is, you're talking about sophisticated cyber criminals who
you would expect to see on the track, or shall I put something else more specific?
Noise.
Maybe
Somebody
just tone this down a bit.
Themselves.
I would go with.
Thank you. Yeah, so ultimately, sometimes you'll have what's called like a kind of a 0-day vulnerability where no one knew about it until someone attacked. So, you can only protect against things that are known about. So there'll always be like an element of not being overconfident, as Charles said, and having your processes to continually monitor. But actually, I think we have a high level of confidence in this as far as that can be given, if that makes sense.
Thanks, Sarah. I think John Robson, you have a question?
Yeah, just the previous speaker talked about using postcode, and he also talked about using LSOA. Now, postcode is an identifiable field, so I was curious as how he got access to that. I don't think he did, because I think what you probably did was to map the postcode to LSOA and then gave him the LSOA. But could you clarify that for me?
Yeah, I probably can't on that specific application, but it is one thing that I would say is a good example of the benefits of this environment, is because we do have the LSOA in it. When on an application someone says, oh, and we need postcodes so that we can look at LSOA, my response would usually be, but actually we've got LSOA, so actually you don't need the postcode because we can just give you the LSOA. So I'm sorry, I can't answer on that particular application whether they did or didn't actually have postcode, but you are right. There are ways that we can give people that kind of aggregate data they actually want. And I think the gap probably is people knowing that and saying that they can tell us what they're trying to achieve. Actually, if you want to know LSOA, we have got that. So you don't need to request postcode if that's the only reason you're asking for postcode.
And I assume that the same thing can happen with the UPRN, the unique property reference number, that you would provide a pseudonymized number, because the actual number is like giving somebody's detailed actual address, 32 Mill Street. So again, you would, I guess, but it means that you must have a mechanism for providing that information from the identifiable information out into the, if you like, the public kind of domain.
Yeah, and again, sorry to keep referring to Ben, but I think this is where, and actually it's a great example, isn't it, of the kind of the crossover between the different, the technical and the IG, but also even like the research governance. And, that there'll be questions that I'll be asking to Ben of like, actually, I don't know much about UPR, and is that identifiable? Is there something else we can give them instead? I don't know if there's anything specific you want to say about the UPRN field, Ben.
Yeah, I mean, we've never given the UPRN out directly to people. Like we've used it so that we can do the mapping to like pollution and stuff like that. But I mean, yes, so if someone requests the UPRN, like it would be identifiable. So there would have to be a basis for that.
Yeah, and I think that's the key, is that there's a level of analysis that can be done, within the system before the data set's provided, without people needing to request the actual identifiable data to kind of do that linkage and mapping themselves.
Okay, thank
Any
you.
other
I think
questions?
I think we should
Thanks.
thank you, Sarah. So Francine, I
Thank
think we should
you.
move on. Yeah.
Yeah, so Conchetta is next. Thank you. And if anyone else has got any other questions, just pop them in the Q&A box and it'll be picked up.
Can you see my screen?
Yeah.
Thank you. Right, so hi everyone. My name is Concetta. I'm a senior data engineer in the data science team in Barts Life Science. I work with Osita on data science project. So today I'm going to give you a quick demo of the tool we have developed so far that Stephen mentioned before. So the idea of this tool is basically that you as a researcher will use this tool to check the population that we have in our trust before putting a request forward for the DAC committee, so that you know more or less the number of patients, the distribution of patients. So the idea is to help you guys to focus more on your research projects rather than spending a lot of time understanding and checking if the data is really there. Especially because for the comment that was made before about knowing SQL. So with this tool, basically, you will skip all that bit and you go directly to the DAC committee saying, I want to do research on this type of population. This is what the patient cohorting tool gave me as a result. And then you basically go ahead with your application in the data committee. So again, the tool is meant to help you researchers, and we developed it using a synthetic database. It gives you general information about demographic, but also some clinical variables. You can also look for diseases and findings using SNOMED terminology, so these clinical concepts that are related to each other. And yeah, again, is to help you guys to make a better research and to focus more really on your project rather than data wrangling. So if my video is starting, yeah, I will give you basically a quick demo. So this is the interface. You connect to the patient cohorting tool using a specific address. The first thing that you will be required to input is a title, and this is because, and it's a required input just because you want to keep track of the searches that have been made, and also because at the end of the search, your search will be saved and stored in the Barts Health data platform, so that when you go to the data committee, this file can be also used to support your application for the data committee. And in the process where Ben is extracting data, you can really have he has an idea of what the data that you are requesting. So basically, again, is to help you, again, focus less on the data rather than and focus more on the project. So here we provide a title. It has to be a minimum of 5 characters. And then we move to other searching criteria. Gender, we put this optional because you might be interested in finding a particular category or not. So if you don't select anything, basically all the categories that you see below will be included in your search. These categories are coming from the NHS England, so they are pretty standardized and they should basically be easily mapped also to other trusts. Minimum age, maximum age, you just move the slider to define the range of the ages that you want to include in your search. Ethnicity, as for gender, this is optional. You can either select something, you can either not select anything, and basically all the categories will be included. And again, even in here, these categories are coming from the NHS England, so pretty standardized category that we also use in our trust. Admission time range, you can define the time range of the admission for the particular cohort that you're looking for. Again, even here, optional. If you don't include anything, all the admissions will be consider it in your search. So in this case, for example, in this demo was the admission range was actually selected. So going from the 1st of January 2016 to the 6th of October 2025. And then the bit below is where you can also look for finding and disorders using SNOMED code. Even in this case, this field is optional, as in if you don't select anything, all the diseases and finding in our data warehouse will be included. For example, if we imagine that we want to look at a specific population, for example, the population with the diabetic foot, so what you do, you start typing diabetic foot in there, and basically all this list that you see below are concept is NOMAD that you can select for defining basically your searching criteria. So in this case, yeah, diabetic foot. And as you can see, once you click on it, the concept basically will be added in the list below. And one thing to note in here is that if you see include one code, basically it means that we are just including the main code of the disease. However, in SNOMED, you have this relationship structure where you have parent codes, child codes. So basically, if you click include child codes, basically you include all the children codes that you have for this concept. And if you don't know what SNOMED is, if you don't know what the children codes are, you can click on the concept and you will be redirected in SNOMED, where you can see the main concept and also the children codes related to that concept. So if we go back again here, you can even define more your search. For example, we can include the patients with diabetes. So if we look for the word diabetes and click on the concept, it will be included. And as you can see in here, the children code is bigger. You have more children codes than the diabetic food. So it's up to you. You can exclude diseases, you can include findings. This bit here is where you exclude what you don't want to see in your population. So for example, in this case, we were looking for people with diabetic foot, but we want to exclude patients, I don't know, who were pregnant in a particular time frame. So what you do, you type pregnancy again as before. Pregnancy would be included. If you include the children codes, just click on just flag the box over there. And then basically that's it. And then now you are ready to submit your research. You can see the submit button is not grayed out just because we provided the title, this is more than 5 characters. If you don't provide a title that is more than 5 characters, this button won't be available. And again, this is because we want to keep track of the searches that are going to be made in this. Clicking submit, you can really see what you have selected so far. For gender, if you remember, we selected all the categories, so it's all. While for ethnicity, we just selected some categories, or even for age. So in that case, you will see the specific categories that you have selected. So now we can press the submit button because we are ready with our search. And then you will be redirected to a new page where you would see the general results of your search. So for example, you see the total number of patients. You can also have some distributions in terms of gender, age, and ethnicity based basically on what you have selected so far. This will be showed in a second. So this is the age distribution and the ethnicity distribution. The good thing of this is that you can always go back to the previous page because the search that you've been doing, it's always there. So for example, you want to expand your population, you just basically go back, reselect what you want or deselect what you want to deselect, click submit, and basically a new page will appear with the new results. And as you can see here, the number of patients has increased because we, of course, included more ethnicities. So I think that's all for the demo. I just have one slide left. Right. So yeah, so as I said, we developed this tool for the past, I would say, 8 months. It was developed using synthetic database, but now we are moving to real-world data with within the Barcell data platform. And we have the official launch of the tool planned for mid-December. So stay tuned, because you might see that in your inbox as an official tool that has been launched. For future announcement, we are currently working on also including the medications. In addition to looking for diseases and fundings, you can also type the specific medication that you want your population to have. And then we are also trying to secure funding now to start developing a second version of the tool that is aimed more for clinical trials. And the difference in there will be the fact that the list of patients that are eligible for a specific clinical trial will be provided. But as you can see, there is more IG going on and secure stuff that we need to plan before really having this version of the tool. And then, yeah, again, the impact that we want in the short term is to support research, to do better research, and to help, researchers to focus more on data on the project rather than on data wrangling. And I think that's all. I just want to thank the National Institute for Health and Care Research, because they funded this project, and also SNOMED, because we collaborated with them in order to integrate the possibility to also look for diseases and funding. Thank you so much. And I'm not sure if there is time for questions, or I'm happy to answer them in the chat.
I think we should move on to Francine. Over to you.
Yeah.
Thank you, Conchetta.
Can everyone see my slides?
Not yet.
It's a Francine. No.
Okay, 1 second. No. I'll try it this way.
Yeah.
Can you see them now?
Yes.
Does that work?
Yeah.
Perfect.
Yep.
Yeah.
Thank you. Hello, everyone. I'm Francine. I'm the Communications and PPIE Manager. So I'm just going to talk to you briefly about some of the things that we've done over the last year. So we still have a long way to go in terms of raising awareness of the platform, but we have strengthened our visibility across the trust. We've increased our press coverage, and we've attended and organised quite a few great events as well. So how have we strengthened our visibility? So we held monthly webinars on WeShare at the beginning of the year, which were basically 30-minute sessions that were open to anyone that was interested in learning more about the platform. And we also gave them opportunities to ask questions and learn about how to use it. We also presented at a few audit days across the trust. And if anyone is aware of any audit days that you might attend or manage, please contact me, because we're looking to present at more over the next few months as well. And then we also shared any news or announcements on WeShare. So you might have seen us pop up in the chat function on WeShare sometimes, or any events on the calendar as well. We launched our public launch in April of 2025, which was a really great event. We had a good turnout. We had some great speakers, and it was a really good opportunity for us to network with people across the trust and externally as well. We also attended and exhibited at the International Clinical Trials Day in May, which is something that we do every year. Hopefully in 2026, we'll be able to present again. We did the Queen Mary Science Fun Day, which was targeted to families and children. This was really good for us because we got to engage with the younger population and try to explain to them what we do in simple terms, but we were also able to engage with their parents, which was useful for us to raise awareness of how our platform works and how it would affect them in the future. And from that event, we actually recruited some public contributors, so that was a good turnout for us. In October, we attended the HDR UK conference in, I was going to say Newcastle. Where was it? Glasgow? Glasgow, yeah. So yeah, that was our first time there. We also had a stand there. And Evan was able to present one of his posters about the work that we're doing, which again was a great opportunity for us because he was able to speak to people at the event and share our work. Then last month, yes, we're in December now, we attended a Careers Day, and it's a second Careers Day that we've done this year. The audience was college students going into university, and I think the one that we did before that were slightly younger, but it was good for us to speak to that generation so that we could let them know the kind of roles that they could go into in the future, but also hand in hand tell them about the platform and what it's doing. I think reaching that population is beneficial for us because it helps us reach people in their parents' age as well. So we're kind of hitting two birds with one stone in that sense. When we launched our imaging tool with Sectra, we were featured in over 30 publications, which was really great exposure for us. We were featured in Health Tech World, a UK Authority, and several more. And then looking ahead, so as I said earlier, we are still trying to raise awareness of our platform across the trust, both internally and externally, sorry. So we're thinking of doing more roadshows, presenting at more audit days, hopefully starting up a Barts Health Data Platform newsletter. And then in terms of public engagement as well, we've just recruited a few people and we've started a patient and public advisory group. And what will come from that is different ideas on how we can actually reach the public and the local communities and share our work across them as well. And then, yeah, that's kind of it in a nutshell. So if anyone's got any questions, please let me know. And then if not, I'll pass back over to Stephen.
So thank you, Francine. Thank you, everyone. Hopefully you can see my slides. So just a couple of things to wrap up on. So the next few months, we've got a number of sort of technical upgrades coming on. We've heard about the patient cohort browser from Conchetta, but we're also looking to upgrade the software that we use to run the secure data environment and the virtual machines that you're able to access inside that. We've also got a new update around the Odyssey data analysis environment, which is used to analyze the OMOP data, which will benefit from users who are looking to do that. And then over in 2026, we're looking to seek external ISO security certification. We're already integrated into the Trust's security policy. And then very much looking to carry on with the outreach to the patients and local community that you heard Francine talking about, as well as bringing on some new technologies that's been going on through work throughout the Trust, in particular in digital pathology, and also supporting the Pharos AI project, which is looking to do federated machine learning between ourselves and other trusts in London. So as you can see, we have a program of work that will stretch through well into beyond next year, but also looking to be very much driven by the needs of users in terms of the data sets, access to data sets, and the linkage between data sets that they need to support their work. There was a question in the chat around charges. Unfortunately, so this is not a service provided by the hospital per se. So we are looking to recover our costs, and that means looking to bring in a income stream to cover the costs around the administration and support of the platform. And you can see an outline of the costs, and those are fairly much comparable with the sort of costs you'd see from looking at either the national NHS England SDE or any of the other SDEs that are available around the country. So just to wrap up with, more information on the activities of the data portal is on the data portal around the data platform and all the work around it. There's also the online application process for getting your project to the Data Access Committee. That is the Barts Health part of it, can usually process those requests in about 4 to 6 weeks, but it very much depends on what additional ethical and other governance approvals you need, and whether those are in place from external sources, and those you need to get externally are obviously things that are beyond our ability to control. And so with that, I'll stop talking. I'd like to thank very much all the speakers, and I'm sure we're happy to stay online for another 5 minutes or so if you have time for any other further questions that you may have. Thank you. So, Jason.
Well, I'd have a question then. So I've just put up the charge bits. So if I was looking to do something like a little QI project within the hospital, so there's a few that are interesting to me in terms of how we navigate and use our war drones, how we make use of our chart in terms of there's all sorts of free text and lack of problem, proper problem recording within the system. I've got a colleague who's interested in making my cardiac surgeons perform more efficiently and effectively as well. If I'm looking at that correctly, that's so the cost charge is 0, but I would have to put the proposal together and submit it. Is there a way that I can like to go fishing?
No,
with an F, not a PH, but actually to look for information
sure.
at a particular time and in a space.
Not directly, no. I mean, that's certainly something you can have a conversation with Ben about, and he can have a look through the data on your behalf to see if the sorts of things that you're after are accessible. But generally, no, we don't allow people to trawl through the data.
Yeah, sorry, I make it sound very suspect, don't I? But yeah, it's all in the good cause, I assure you.
Yeah.
Thank you.
Okay, so I'm not seeing any other questions on the Q&A, and there aren't any others on the chat. So the question is around, there's been a couple of questions about sharing the presentations and a link to the recording. Francine, were you planning to collect those and put those up on a and put those on one of the events page?
Yes, so the recording will be on our website, and I could potentially send out the slides as well if any of the presenters could send them to me, and then I can send it to everyone that attended.
Okay, so Conchetta.
Yeah, just a quick note on my side. I'm happy to share the slides, but I have the video embedded, so it won't be shared in the slide just because I cannot send it. The file is too big, but people can always refer back to the recording where the video basically was showed.
Thank you. All right. Any other questions?
I think there is a hand up, Stephen.
William, hand up. William?
Hi, thank you. I think my question is perhaps a follow-on from Jason's. Just obviously recognizing the data charges for using the platform. Obviously, a lot of us researchers will need to have funding to be able to utilize it, and obviously funders are going to want kind of demonstration of feasibility of any projects, and for that having kind of robust numbers is helpful. And so, for example, if I wanted to do a project on patients who'd had a myocardial infarction and needed to show how many had had an angiogram, for example, at Barts, and that was available. Completely appreciating, obviously, the resources of your team is limited. Is it reasonable to kind of send a request in order to not have any kind of detailed information, but simply, you know, what are the numbers, so I could then put it into my grant proposal, for example? Is that something that's considered reasonable to do?
Indeed, there are two request models you can make through the data portal. One is a full proposal, and the other is a provisional proposal. And that provisional one is exactly if you're in the sort of the pre-grant submission phase. Is that one you can make the application, it can go through the Data Access Committee. We can give it a provisional thumbs up, which helps to support your grant request and helps to identify any concerns that we might have with the proposal that you can then strengthen during the grant and in preparation then for making the full proposal. But certainly if part of that request was in terms of identifying the size of the cohort, then that would be a reasonable thing to do, as you know, provided that was a relatively cheap from our perspective of to do that. And hopefully when the cohorting tool is in place, that will be something to some extent you should be able to do in a sort of self-service mode to see what sort of profile of patients there are for the particular areas that you're looking at.
Thank you, that's really helpful.
Ben, do you want to follow up on that?
Yeah. Just two things. Like, yeah, as you said, like as long as the query is straightforward and one of my team can run it pretty fast, like that's fine. There is also HGR UK has a OMOP based cohorting tool that we're online with. So that's not something that we control, but it does have possibly more data in it right now. So that's another option if you want to like basically where you can sort of do phishing kind of things to some degree.
Okay. Anything else?
No, there's nothing in the Q&A, and there are no more questions in the chat either.
Okay, well then let's take the opportunity to wrap this up as we're a little bit over time. Thank you very much everyone for attending, and thank you very much for the questions and your ongoing interest and support. So with that, thank you and goodbye.
Thank you, everyone.
Bye.